We'll start by the subspecialty lecture. I am Hatem Kalantan, Associate Professor and Consultant in King Saud University. Is my voice clear?
Yes, doctor.
Okay. Nice. Our subspecialty lecture today, it will be about intraoperative and postoperative complications of cataract surgery. We'll start with the intraoperative complication. We'll start by the block complication or local anesthesia complication. Most of the cataract surgery today is done under topical anesthesia, but for some cases we need to block the patient and doing peribulbar or retrobulbar anesthesia and cooperative patient or another indications. So one of the complications that might arise when you do your block is retrobulbar hemorrhage. The incidence of that is 1 to 3%, and you would identify it immediately. The patient will start to have proptosis with high intraocular pressure, and when you try to open the lid, you will feel that there is tense lids, and there will be developing 360 subconjunctival hemorrhage or ecchymosis. And if it is left long enough, it can cause subsequent irreversible optic atrophy. So what we do if we encounter that directly after our block, we have to massage the eye and do measures to lower the intraocular pressure, in addition to doing lateral canthotomy and cantholysis. Canthotomy sometimes is not enough to relieve the pressure of the globe, and we have to do cantholysis, which is avulsion of the tendon that is attached to the inferior orbiter. Also, we can do AC paracentesis or 360 conjunctival protomy. All of these measures are intended to lower the pressure from the blood arising in the globe that compress the globe and the optic nerve. Another complication of the block is perforation. Whenever we insert the needle, we take care not to touch the globe and be away from the globe. But in certain cases, especially with longer eye and the presence of staphyloma, sometimes we encounter the eye globe and hit it inadvertently with anesthetizing needle. Also, wrong technique if we are not accustomed to go away from the globe, directing our needle away from the globe, or if there is a deep-seated eye and we are trying to give the block, we have some chance of hitting the globe and perforating it. And sometimes this might not be discovered until you are doing or starting your procedure. And if you started your procedure, you will feel that the globe is soft and the AC anterior chamber is deeper than usual. And if you notice in the posterior part of the eye, you will see some dimming of the reflex or some floating vitreous hemorrhage beyond your focus or work. So what to do in these cases if discovered either before the procedure or during the procedure? We eventually have to refer it to the retinal specialist to do pars plana vitrectomy and to release this traction, and sometimes it gets very bad and hitting the macula, which end up in really bad prognosis. When we start and we are doing our capsule Rhexis, the most famous of which during capsule Rhexis is extension or escape of this capsule Rhexis, first of all beyond the pupil, and then it can go to the equator, and if it is extended, it can go even to the posterior capsule. And we found this radial extension, especially if there is intumescent cataract. Why? Because there is a pressure inside the lens, and when we open the anterior capsule, the content of the lens tends to go out. So this causes the Rhexis to escape in uncontrollable manner. So to avoid this, we have to inflate the anterior chamber with a good amount of viscoelastic material. Most of the time, we inject viscoelastic material, but we don't fill it properly. I am telling the residents all of the time that inject in the anterior chamber the viscoelastic until you see the visco coming from the eye. This means that it is full of the viscoelastic. Other thing is that we don't tend to inject viscoelastic right away after we enter the anterior chamber. I tend to go to the other side of the eye before starting the injection, and this allows the aqueous inside the eye to go outside and replaced by viscoelastic. While if you inject it right away after entering the eye, you might fill half of the anterior chamber and the other half will be filled with trapped aqueous inside. So if we felt the Rhexis is getting out or trying to escape, we just stop and we inject viscoelastic to substitute whatever viscoelastic that might escape during our first half, for example, of the Rhexis. And then we have good pressure in the anterior chamber, and then we hold the capsule and we direct our tension or pulling to the center of the eye. This usually have corrective movement of the Rhexis. Instead of escaping out, it tends to go in. So this is one of the tricks that I learned over the years, that it might save the Rhexis from escaping and getting to the equator and eventually to the posterior capsule. Another Rhexis complication is small Rhexis. Sometimes we are afraid of the extension, so we keep our Rhexis to the smaller side. But what happens if we ended up with 4 millimeter Rhexis or smaller? This will be making the subsequent step of phacoemulsification, trying to get pieces, especially if large nucleus or hard nucleus. This will get very difficult, and sometimes the tension of manipulation will be transmitted to the zonules, causing zonular dialysis and complications. So we are aiming usually for a 5 millimeter Rhexis. So the Rhexis doesn't have to be very small, and it doesn't have to be very large. It's large enough to cover the optic at the end of the surgery. So 5 millimeter will do. On the other hand, large Rhexis is good for manipulation of large pieces of the nucleus, and also for hard nuclei, but the centration and the IOL tendency to go forward outside of the large Rhexis is a problem at the end of the surgery. And if we felt that any part of the IOL is not covered by the Rhexis, I would advise to use intracameral myocol at the end of the surgery to secure this lens in position. Because even if micro leak happened during the first post-op period, this lens tends to go forward, and you will find it next day with a pupillary capture, which you don't like to see. Another intraoperative event that you might encounter during surgery is the shallow chamber, and this is really an annoying event during surgery, but can be corrected. And this is we have to discover the cause of the shallow chamber during the surgery. The causes are either inadequate infusion of the BSS, so the bottle that is supplying infusion to the eye and keeping it forming. The chamber might not be enough. Other is wound leak. You might infuse enough, but the output or what's coming out of the eye is more than what is incoming of the eye, and this will have the wound leaking and causing shallow chamber. Third reason is a positive vitreous pressure, especially if the patient is obese or having short neck or having pulmonary disease, having difficulty with the breathing or anxiety that is applying some force. Even when the eye is fully akinetic because of the anesthesia. If the patient trained enough, he can cause shallow chamber. I remember one of the patients that is having frozen globe after the anesthesia, but he kept having shallow chamber. We couldn't complete the surgery unless we put the patient to general anesthesia. Another reason for shallow chamber during the surgery is aqueous misdirection. This happens when the fluid goes behind the lens in the anterior vitreous space and pushing the iris lens diaphragm forward, so that you will not have space for phacoemulsification, and you might encounter complication, either corneal or posterior capsule hit. Also, the suprachoroidal hemorrhage, which is a disaster complication during the surgery, it can be manifested early on by shallowing of the chamber, following by decreased red reflex and the other sequelae of the suprachoroidal hemorrhage. So what we do, if there is inadequate infusion of the BSS, we just ask to raise the bottle, so infusing more BSS during the surgery. Suturing the wound, if you had a large wound and you have leaking fluid from both sides of the wound or from the paracentesis, when it is large, you suture it and then you continue your surgery. Sometimes the speculum is the one causing pressure on the eye, so just revise the position of the speculum and make sure that it is not pressing on the eye, and if it is pressing, either it or the drip, try to adjust it before resuming your procedure. Intravenous mannitol, also one of the things that can help you during surgery to deepen the chamber. So what happens usually in aqueous misdirection intraoperatively? As I told you, the fluid is directed to the anterior vitreous instead of keeping itself into the anterior and posterior chamber. And with this fluid accumulation, the iris lens diaphragm, as you can see here in the picture, is pushed further and further anteriorly, and the space becomes narrower and narrower. And it happens during hydrodissection, or at any stage of the procedure, you can have it, and you will have this sequence of events. And what to do? If it is bag blocking syndrome, we can tap the nucleus and allow the fluid that is trapped behind the nucleus and anterior to the capsule to go forward through the periphery and the equator of the lens and deep in the chamber. We can do IV mannitol to the patient to dehydrate the vitreous and shrink it and having more space. And we can also insert a 19 gauge needle in the pars plana and aspirate, but you have to do this with cautious because this you'll go most of the time blindly, and the aspiration itself can have some traction effect on the retina. Pars plana vitrectomy can also help to treat this aqueous misdirection altogether. So let's move to the complication that all of us that is afraid to have during cataract surgery, which is the posterior capsule rupture. Posterior capsule rupture can happen either with nucleus removal, with cortical aspiration, or even as early as when you are doing capsulorhexis. As I told you before, the capsulorhexis escapes going to the equator, and then it extends further. It reaches the posterior capsule. Or vigorous hydrodissection, if you are doing a lot of pressure with the hydrodissection, this can overcome the tensile strength of the posterior capsule and it can open. So when this happens, identifying is important. So you can see it like in this picture. You see the posterior capsule. It is open and it tends to rule with the irrigation fluid. And when this happens, usually try to differentiate between posterior capsule rupture alone and posterior capsule rupture with vitreous prolapse, because when it happens early on, we tend not to have the vitreous prolapse. So we can complete the case having only posterior capsule rupture without vitreous prolapse, and with this will give better prognosis after all, and this complication after that. And how not to have the vitreous into the anterior chamber is when we keep the irrigation and we identify the posterior capsule rupture, and our initial response is withdraw everything out of the eye, and this will decrease the pressure in the anterior chamber. And what will happen to the vitreous? Vitreous will find less pressure chamber, and it will creep to the anterior chamber. So what to do to avoid this is, before we go outside of the eye, we move to position 0, and then we inject viscoelastic material, and then you can go out. So go out, take a deep breath, reassess the situation, and whenever you are going out of the eye, try to do this maneuver, not to invite the vitreous to the AC, and then it can go to the wound, and then the prognosis is going down and down. So what happens if there is inevitable vitreous loss? You are doing everything and the vitreous is still coming forward. The rule is, whenever the vitreous come to the AC, we have to excise it. So how to excise it? The practice of having Wixel and cutting it, this will cause some traction to the vitreous, especially at the vitreous base. And what is there in the vitreous base? There is a peripheral retina, and when you pull on the peripheral retina, you will cause peripheral retinal break, and this can predispose to retinal detachment early on. So use the vitreous cutter, the Q-tome, and preferably by bimanual technique. With the coaxial technique, it was shown that there was increased tendency whenever you cut the vitreous, irrigation will invite more vitreous, and so on and so forth. But if you have the irrigation from another port and you are cutting from another port, you are cutting the vitreous and maintaining the AC formed, and the rest of the vitreous will be kept back. How can we see the vitreous? We cannot see the vitreous. The vitreous is transparent, and we can only see the clues of the vitreous, or if there is debris on the vitreous. So how can we put some debris to see the vitreous? We inject steroid, which is triamcinolone or Canalog. We inject it into the anterior chamber, then try to wash it, and we can see the strand of the vitreous that is extending and that needs to be cut by the Q-tome before continuing the procedure. Vitreous can cause into the wound, causing inflammation, and it can touch the cornea, causing corneal decompensation, or it is, when it's left long enough, it can cause cystoid macular edema. Another thing that can happen also is the dropped nucleus. No one wants to have a dropped nucleus, and this usually happens if the rupture was created before complete removal of nuclear fragment. And most of the time, we don't identify the posterior capsule rupture before the nucleus is dropped because if we identify it, we will be more careful. But most of the time, whenever the nucleus is dropped, there is a rupture that we didn't identify, and we continued as usual, and we continued with the same setting, and this will cause the nucleus to drop. So whenever nucleus is dropped, don't try to chase it. Okay, there is a tendency, I don't want this to happen, and the nucleus is there within reach. I can go a little bit deeper to catch it. This will only make the situation worse. So don't try, just accept that you lost the nucleus, do anterior vitrectomy, do your corneal cleaning, cortical cleaning, and put the intraocular lens and suture the wound, and then refer to retina surgeon for pars plana vitrectomy for removal of this retained nucleus fragment. Dropped IOL. Dropped IOL happens if the capsular support seems enough while it is not. Sometimes we have complication, we manage it, we do anterior vitrectomy, and we have the bag in front of us or even the sulcus, and we insert our intraocular lens. If the capsular support, you are not 100% sure that it will support your lens, it's better to leave the patient rather than to complicate the issue by dropped nucleus and dropped IOL or dropped IOL that might be implanted later by secondary IOL insertion when the view is clear and there is no corneal edema. We want also avoid the issue of facing the patient, explaining to him, but sometimes you have to go by the safer way. It's better for the patient. Zonial dialysis. Zonial dialysis, this is a complication that happen when there is enough traction of the capsular bag to avulse the zonule. Usually zonules are pretty strong, but if your manipulation is stronger than the zonules, they will avulse. This happens usually with patients with the pseudo exfoliation when there is pre-existing zonular weakness. Usually I advise that you decrease your manipulation to the minimum when you have pre-existing zonular dialysis, so that vigorous rotation or maneuver, pulling the piece while you are watching the bag moving toward you, this definitely will end up in zonular dialysis. So what would we do if we have inevitable zonular dialysis? If it is less than 180 degree or up to 180 degree, we can implant a capsular tension ring, and this can tamponate the equator of the capsule and make it strong enough to accommodate the intraocular lens. But if it is more than 180 degree, even if you insert the capsular tension ring in the bag, it will still be decentered. So you will have to have a suturable capsular tension ring or segment to maintain this bag in place. So iris dialysis is another complication. We saw this when we are doing our phaco emulsification, and we inadvertently aspirate the iris, and we aspirate it with enough strength to disinsert it from its iris root. And when this happens, it's either a small iris dialysis or it is big. When it is small, it can be left alone, especially if it is superior and it is covered by the lens, by the lids. But if it is large and you are sure that this can cause monocular diplopia for the patient, if left, we will have to suture it back by non-absorbable sutures. Wound burn. Wound burn happen when there is hard nucleus and we are using a lot of power, so the temperature of the probe elevates and it is causing the wound to contract by the burn. So if this happens, most of the time it is difficult for suturing it. It will keep leaking, and sometimes for as small as this one, we have to close it by 3-5 sutures before it is watertight. And with the sutures and the tension that is needed, significant astigmatism usually arises with the wound burn. So to avoid this, having some BSS continuously dropped over the phaco probe in the wound during the procedure by the assistants will decrease the incidence of wound burn. Right. What about the Descemet detachment? Descemet detachment can cause localized corneal edema that can be noticed during the surgery and usually happens near the wound during irrigation or separation by instrument while going in and pushing the Descemet. To insert the instrument into the eye, I usually tell that at the tip of the instrument go a little bit vertical until you pass the Descemet, then you can go horizontal. If your intention is to go horizontal, then go further. First of all, vertical to pass the Descemet, then go horizontal. And this is the cause of difficulty for putting the instrument in and out. I see a lot of us struggling to get the instrument inside the eye. So a small tip is just to make the tip vertical at the start, and then when you pass the Descemet and you are in the AC, go back horizontal. If there is a small detachment that is there near the wound, we can tamponade it by air bubble in the AC, and then we position the patient accordingly. So, for example, if the patient is having a temporal wound and you are seeing some limited detachment there, after you are putting the bubble, you instruct the patient to lie on the other side. So you always the air goes up, and when the patient lies to the other side, up is temporal, and it will tamponade the Descemet detachment that is there. Sometimes we need longer tamponading period, so we use expansile gas, gases of the retina, SF6, or even C3, F8, that can stay in the eye longer period of time. Sometimes we have to suture this detached Descemet to keep it in place. How to diagnose Descemet detachment? We can see it in the slit lamp together with the edema. Sometimes you have edema that you cannot see beyond, so you have to do like this here, OCT or UBM, or putting some dehydrating drops before you can examine and see and diagnose Descemet detachment. Suprachoroidal expulsive hemorrhage. This is sinister complication, and there will be sudden increase in the intraocular pressure with dimming of the red reflex while you are operating, and all of the intraocular content tend to go out of the wound. If it is a big wound, you see the iris, vitreous, everything is trying to go outside of the eye with the bright blood. So if you identify this early by shallowing of the chamber, dimming of the reflex, and tendency of the intraocular lens of the intraocular content to go out, we have to close the wound immediately. We want to preserve the intraocular content inside the eye, either by a fast closure of the wound. Sometimes we have to put our finger in the wound so that the intraocular contents doesn't go out, and close the eye. And if we manage to put our finger there, say for example ECC wound, we try to close the eye initially by even large suture, 6/0 silk or 6/0 silk or something, and then if we are sure that we are enclose all the intraocular content inside with a secure wound, we can do posterior sclerotomy, trying to evacuate the blood. And there is a controversy about doing a posterior sclerotomy at this time or deferring it out later on. Is a matter of debate, because some argue that doing posterior sclerotomy inviting more blood, and this will have a vicious circle and it will not stop. So just based on your best guess, just do or do not do posterior sclerotomy. This is the intraoperative complication, and now we move to postoperative complication. We have early ones and we have late ones. The early ones, first day, you are opening the patch of the patient and you see the chamber is shallow. Chamber is shallow with low IOP, either because of wound leak, we switch to the wound, choroidal effusion, we put topical frequent steroid with cycloplegic. But if the intraocular pressure is high, this might be due to pupillary block. We have to do a PI, aqueous misdirection. Even if there is a PI, the aqueous misdirection have the shallow chamber with high IOP, or even it can be due to suprachoroidal hemorrhage. You can see it by fundus exam or doing a B scan. If there is a wound leak, the patient usually coming complaining of tearing. Even under the patch, the patient is telling that the eye was watering so much under the patch. So take this seriously and check for leak. The intraocular pressure can either be low or be normal or even be high with wound leak, but low IOP can be suggestive of that the leak is not secure enough. The AC also, it can be shallow if there is profuse leak, or it can still be formed with some leaking. And we diagnose it by sidal test. As you know, we put fluorescein, visualizing it with cobalt blue. You will see the fluid coming from inside the eye, diluting the fluorescein. So what to do? Suppressant, decreasing the topical steroid, allowing the wound to heal, putting the contact lens or pressure patch. In the past, we used to use gentamicin eye drop. We know that it is irritant and it will have the tissue heals faster, but the safer of all is just to take the patient back and resuture it under sterile technique, because if we did these previous measures, you are in the hope that the patient will not have organism just getting inside the eye and causing endophthalmitis. So what we would advise is just take the patient back to the OR or minor OR and resuture and make sure that the wound is secure before letting the patient go. Wound gapping. Wound gapping can have a leak or it can be without leak. The iris can come there and become incarcerated there and stopping the leak. And IOP might be normal, AC is formed because there is no leak. It can give rise to bleb formation if it is gapping under the conjunctiva. So we can observe unless there is irritation or shallow AC or significant hypotony. And at most of the cases, we have to do complete wound revision or cauterize the wound to close the wound and make sure that it is secure. Anterior segment bleeding, hyphema, can happen, and usually it originates from the incision itself or from the iris root, and usually resolves spontaneously if the patient doesn't have any bleeding tendency and he's not on anticoagulant. If he's on anticoagulant or antiplatelet, it might need to be stopped. The wash out or going back inside for AC wash out using Simco is indicated whether there is medically uncontrolled intraocular pressure or there is a risk of corneal staining because of prolonged hyphema. Choroidal effusion. The risk factor of having choroidal effusion postoperatively are hypertension, obesity, high myop patients on anticoagulant, glaucoma patient, or patient with chronic ocular inflammation. And it happens less with phacoemulsification in comparison to the extracapsular cataract or large incision cataract surgery. The patient with choroidal effusion having low intraocular pressure, and this low intraocular pressure can have more choroidal effusion, and it is a vicious circle, and it can be a precursor of suprachoroidal hemorrhage. So management is observation, frequent topical steroid, cycloplegic medication. Suprachoroidal hemorrhage can happen intraoperatively, or it can happen also in the postoperative period, either early or late. The patient will come complaining of pain, decrease in vision, chamber is shallow with high intraocular pressure. And the treatment, first of all, we control the intraocular pressure medically, and we ensure that the wound is secure. There are some indications to surgery if we have persistent flat chamber, iris touching a cornea or lens is touching a cornea, and this doesn't improve over time. We have to intervene. Medically uncontrolled glaucoma also is another indication. Kissing choroid, if you have kissing choroid, this is an indication for surgical intervention or persistent choroidal detachment. What about high intraocular pressure? This is a very common complication after surgery. We find the patient in the first day with high intraocular pressure, and most of the time this is due to viscoelastic remnant. And especially with dispersive viscoelastic, just take your time at the end of the surgery to remove it all. Even sometimes I go under the intraocular pressure to remove the viscoelastic, because this type of viscoelastic, which is the dispersive one, it's not easy to remove, and it comes in pieces rather than one bubble in cohesive viscoelastic. Another cause of high intraocular pressure is pupillary block, and here you will find the chamber is shallow, and you will have to do a PI to just break the pathogenesis of this pupillary block. And it may follow resolved wound leak. The wound is leaking and the pressure is okay, then you suture the wound, the intraocular pressure might go up. Postoperative uveitis, AC, IOL, because of pupillary block, if there is the PI is not patent. So it needs a PI. Trial of dilation may break the attack, but the definitive answer is the PI. Malignant glaucoma or aqueous misdirection can be a cause of high intraocular pressure in the first post-op period, or even suprachoroidal hemorrhage. But if you encounter the aqueous misdirection in the first early post-op period, the angle-closure glaucoma patients are more at risk of aqueous misdirection, and the intraocular pressure is high despite the presence of a patent PI. So if you did a PI and the chamber doesn't want to form, so keep in mind that this might be an aqueous misdirection. Medical management, IOP lowering agent, cycloplegic we can do. YAG capsulotomy, we disrupt the anterior hyaloid face. We want the fluid, instead of accumulating behind the lens, to be diffusing anteriorly to form the chamber. Sometimes in the resistant cases, we have to do pars plana vitrectomy as the ultimate solution of malignant glaucoma or aqueous misdirection. Other causes of high intraocular pressure after surgery: hyphema, ciliary block, endophthalmitis, retained lens material, iris pigment release, pre-existing glaucoma or stereoidios, or peripheral anterior synechia. Corneal edema postoperatively, that is happening. It is have a higher incidence of happening with pre-existing corneal endothelial dystrophy, like Fox endothelial dystrophy, when you have dysfunctioning endothelial cells, or previous surgeries that made the count lower and lower, and whenever you have surgery, the edema, it will not clearing. It happened due to mechanical trauma or prolonged irrigation. Sometimes we don't use a lot of phaco power during surgery, yet we have corneal edema after the surgery. This happens with prolonged irrigation. There is a fluidic with the phaco procedure, and this fluidic having some certain form of trauma on the endothelium, especially if the procedure took too much time, you are losing endothelium with time. Inflammation also can cause corneal edema, high intraocular pressure. The high intraocular pressure corneal edema usually In the epithelial side, you'll find epithelial edema with microbully. Sometimes when you see it, you know that pressure is high. TAS, what is TAS? TAS is toxic anterior segment syndrome. I will come to talk about later. There is a syndrome called Brown-McLean syndrome. This is a peripheral corneal edema without central one, and usually happening after intracapsular cataract extraction. Intracapsular cataract extraction now is history. No one is doing it, but for some indications, sometimes when we are finding very unstable bag, we have to remove everything at once, and this is planned rather than having it as a sequence of the procedure. It can progress of corneal decompensation, or it can be just transient, and whenever the endothelium recovers, the cornea can clear again. In endophthalmitis, there can be a lecture or more about this topic, but classically, the patient coming with pain, decreased vision, floaters, and photophobia. And typically, the patient coming per se postoperatively without symptoms, without signs, but afterward, in the period of 2 to 5 days, things escalate very quickly, and the patient will have profound decrease in vision, redness, pain, lid swelling, and it has to be treated by urgent vitreous tab and intravitreous antibiotic, unless the vision is very poor, so the level of light perception, the patient might need to have vitrectomy for better outcome. Cystoid macular edema, this is a fairly common complication after cataract surgery, and we discovered it clinically in 1 to 2% of the patient, while if we did angiography, fundus fluorescein angiography for all the cataract patients, we'll find up to 11% having cystoid macular edema, and it is more with complicated surgery, can be part of urban gas syndrome, and may result from perifoveal capillary permeability due to generalized intraocular vascular permeability. Other contributing factor is prostaglandin release, visceromacular traction, transient or prolonged hypotony during the surgery. It can resolve spontaneously. This is the OCT picture. It is delineating clearly that there is a fluid space under the retina, and it can be further delineated by the use of fundus fluorescein angiography. Treatment of cystoid macular edema can be by topical steroid, topical non-steroid, oral non-steroid, or sometimes we injecting the steroid subtenon for that disease entity, oral carbonic anhydrase inhibitor, Diamox or acetazolamide, laser grid, or even pars plana vitrectomy is needed in some resistant cases. Epithelial growth, epithelium can grow inside through the wound, if it is, especially if it is insecure, and it can go inside the eye and cover the endothelium and the iris. We can see it on the slit lamp, and the intraocular pressure usually is high with abnormal ocular iris surface, pupil distortion, and you can see this retrocorneal membrane. And if you are not sure that is this an epithelial growth or not, you can do a diagnostic procedure, which is argon laser. You hit this membrane, and if it turns white, this most likely an epithelium. Retained lens material. So after the surgery, if we had some pieces escaped into the vitreous cavity, this can give rise to uveitis, glaucoma, corneal edema, and vitreous opacity. Do we have to remove these pieces? Yes, if there is resistant inflammation, if there is medically uncontrolled glaucoma, or the piece is very large that it cannot be left to dissolve over time. If there is a nucleus piece, not only a cortex. If there is retinal tear or detachment, we have to remove it and do the proper treatment of the retina, or if there is endophthalmitis, so we can do injection of intravitreal antibiotic at the same time. Surgical removal shall be within 7 to 14 days. So at the start, usually we don't do the procedure because of corneal edema and to control the intraocular pressure, but we must not delay it beyond 3 weeks because there is an increased chances of chronic glaucoma and cystoid macular edema. So what is toxic anterior segment syndrome? It is toxicity to the corneal endothelium that can happen due to certain irrigation solution. If you don't use the advised irrigation solution inside the eye, or improperly prepared intracameral injection, either intracameral acetylcholine or intracameral cefuroxime, or if it is not prepared in the proper concentrations, it might cause the endothelium to have toxicity. It has been reported with also subconjunctival antibiotics, skin cleanser containing chlorhexidine, and the corneal edema can be temporary or permanent, and this can resemble actually the endophthalmitis the patient can have with the severe reaction inside the anterior chamber with corneal edema. Sometimes this severe reaction can cause also hypopyon. So we can have to differentiate between it and endophthalmitis and treat it by frequent topical steroid. Uveitis glaucoma hyphema syndrome usually happens with anterior chamber intraocular lens and maybe due to inappropriate sizing of the ACIOL. There will be friction of the IOL with the iris, causing release of inflammatory cells in the anterior chamber and causing glaucoma, and also ongoing bleeding due to this friction. And it is treated medically by topical steroid and anti-glaucoma, but for some resistant cases, we have to remove the intraocular lens to get rid of this syndrome. What about the late post-operative complication? Late IOL subluxation. Sometimes we put the lens, it is in position, but later on we had a subluxation of the lens. Pupillary capture, as if you see in this picture, the IOL haptic is in front of the iris, superior and inferiorly. And if it is left, there will be formation of synechia between the iris and the capsule, and this will be permanent position of the lens. And sometimes this happens due to improper implantation of the haptic. And that's why, especially in, for example, we have posterior capsule rupture and we had to put a 3-piece IOL in the sulcus. I would advise for the optic to be captured by the remaining Rhexis to be kept in a posterior position and away from the iris, not to have this picture. Forward movement of the optic can cause this capture. Usually it is asymptomatic, but it can occasionally give rise to glare, photophobia, monocular diplopia, in which situation we have to interfere surgically to reposition this IOL. Midriatic can be tried out, but surgical syneculitis may be necessary to get this lens back in place. So this picture showing IOL is going inferiorly, and this can happen if there is improper implantation of the haptic, one in the bag, for example, and the other in the sulcus. So for example, if the superior haptic in the bag and the inferior in the sulcus, and you know that the sulcus diameter is larger than the bag diameter, so there is tendency for the whole intraocular lens to move to the roomy area. If there is insufficient zonular support, can cause this late zonular IOL subluxation. A regular capsular bag contraction can cause also the subluxation. So how we manage this type of complication? If it is really bisecting the visual axis and causing the patient diplopia, we have to interfere in getting this lens in position centrally again. Simple repositioning. And if we found that there is tendency for subluxation, we can suture this intraocular lens either to the iris or to the sclera, or sometimes we find that the whole back IOL complex is the one that is subluxating. So we can take this complex again and suture it to the sclera. Induced astigmatism by tight sutures. In cases of ECCE, we tend to wait 6 to 8 weeks until the wound matures before we relax the suture to get rid of this induced astigmatism. If there is wound gapping, there is a tendency for against the rule astigmatism because it will be flat in the axial meridian and the steepness will be horizontally rather than vertically. This is in superior ECCE. Refractive surprise, it can be to error in preoperative IOL calculation. If there is error, back in the days we used A-scan, in which we have to touch the cornea by the A-scan probe, and if we are not careful enough and we indented the cornea during the A-scan procedure, we can end up with wrong axial length, and this if put into the formula, we end up with the wrong IOL. It can give us refractive surprise afterwards. So the patient, instead of being immetrope as we planned, you find him to have high myopia or high hyperopia. Also, another cause is IOL inversion during the insertion. We put it upside down, so the angulation is different, and there will be refractive surprise. It can be less frequently by manufacturing defects or packaging of the lens or mislabeling. And the reason that we see nowadays that is increasing is the previous corneal refractive surgery. Another lecture can be put about how to predict with high accuracy the corneal power after corneal refractive surgery. But bottom line, if we use the conventional method for IOL calculation in patients who underwent previously refractive surgery, we will end up with refractive surprise. So we have to take this in mind, ask every patient whether or not he underwent refractive surgery in the past before doing his IOL calculation. What to do? Glasses, if there is a mild refractive error, contact lens, and even IOL exchange, we can change the IOL with the correct one, or we can put a piggyback IOL. There is a certain type that's called sulcoflex. You can insert the intraocular lens on top of the previous lens, or we can do corneal refractive surgery to correct the remaining refractive error or the refractive surprise that happened afterwards. Corneal decompensation usually happens in patients with pre-existing corneal epithelial dysfunction, as I told you, functional epithelial dystrophy or previous surgical trauma. A lot of surgeries, for example, the patient underwent. So any more surgery that can cause more endothelial loss and predispose to corneal decompensation. Using much energy during phacoemulsification, so this induces heat and kills more endothelial cell, and the remaining cell will not be able to cope to dehydrate the cornea, ending up with corneal decompensation. Vitreous contact with the wound can play an irritating role to the corneal endothelium, decreasing in its density over time, leading finally to corneal decompensation. So how does the patient present? Pain, decrease in vision, risk of corneal ulcer because of rupture of bulli. We have to treat the patient initially with frequent steroids, sodium chloride, bandage contact lens. But if it is persistent and there is good visual potential, the patient will need to replace this diseased endothelium by the posterior keratoplasty, DSEK, DMEK, or if there is scarring that is already happening to the stroma, we can do full thickness corneal transplantation or PKB. If there is no visual potential or there is no light perception in that eye due to some other reason, we can do conjunctival flap, or even cross-linking have been described to decrease the symptom of corneal decompensation. Chronic endophthalmitis, it happens weeks or months after the surgery, and usually low virulent organism, most famous of which is Propionibacterium acne. The patient presents with chronic inflammation after surgery that is responding to topical steroid. Whenever you decrease or discontinue the steroid, the inflammation comes back. If you examine carefully, you will find some plaques on the capsule of the lens. This corresponds to the organism inside the eye. So what to do in these cases? Injection of intravitreal antibiotic or vitrectomy with or without removal of the whole lens capsule complex to get rid of this problem. Posterior capsular opacity is the most common complication of cataract surgery, 28% in 5 years. And we have different forms like Samaring ring, which is the adhesion of anterior and posterior capsule, peripherally Erschning pierce, outward migration of epithelial cells, like in this picture, or capsular fibrosis from the epithelial cells transforming into myofibroblasts. The treatment is simple, YAG capsulotomy. Risk factor, young age, intraocular inflammation, pseudoexfoliation, IOL design, IOL material like acrylic, silicone, TMA are more. Silicone oil in the eye can predispose to this complication. Anterior capsule phimosis, the same risk factors for the PCO. Symptoms glare, especially at night, occur with small Rhexis, pseudoexfoliation, Marfan, surgical trauma, plate haptic. The treatment is by doing some relaxing radial incision into the anterior capsular Rhexis and relax this phimosis. Corneal melting. Corneal melting can happen in patients with pre-existing tear film instability due to collagen vascular diseases. So we have to lubricate the patient well, or even put punctal plugs or lateral tarsorrhaphy in the patient with severe dry eyes. If perforated, we need to glue it or having a patch graft to close this perforation. Cyclodialysis, the patient will present with decreased intraocular pressure, and there will be separation of ciliary body from the ciliary sphere. It might result from manipulation of IOL extensively. A prolonged hypotony can happen, in which the case the cleft has to be closed either by argon laser or by suturing. Retinal detachment can happen less than 1% within 6 months of the cataract surgery or after capsulotomy, which disrupt the vitreous. More with axial myopia, lattice, previous tear, detachment, retinal detachment, the pillow eye, posterior capsule tear, vitreous loss, and posterior YAG capsulotomy. If there is no visual improvement after surgery, despite that we looked over and found there is nothing, it might be due to retinal toxicity, and it can be due to prolonged microscope light. It says that assumes that it can burn the RPE if proper filters are not used, and it can cause also foveal burn and paracentral scotoma with this prolonged use. And we can avoid this by minimizing exposure to coaxial light. In the microscope, as you know, that we have diffuse or oblique light, and we have also the coaxial light, that the light is going to the eye and reflected back. And this light, the coaxial light, we need it during certain steps of the procedure, not all the steps of the procedure, especially with steps that is dealing with visualization of the posterior capsule. We need this coaxial light. But for example, for suturing of the wound, something outside, you don't need this coaxial light. So you can turn it off to decrease the exposure to this light. That's it. Thank you very much. So if anyone have any question, please go ahead.